and he is going to talk on light chain diseases from his perspective. And I would like to invite Dr. Abhijit Kundu sir and Umapati Hegde sir for sharing the session. Please.
Good morning. Thank you for the invitation, and it's always a pleasure to come to Nadiad an institute where we've always looked up to as a place for academic excellence. And Dr. Rajapurkar has supported me a lot in my initial years and encouraged me. And then we developed relationship with all the other faculty over the years. It was interesting to hear the previous talks that a number of papers were quoted from hematology journals and oncology journals, and there was a lot of cross specialty discussion. So my talk is about light chain disease, where you know a lot more about the diagnosis, and I was told that I should stick to the hematologist part. I will try to do that. Initial slides may be some overlap, but then I would go to the treatment part. And the other interesting perspective I was thinking from the previous talks is that for a 50 to 80% recurrence, you are not willing to transplant, which for us is extremely common, that for a 20% survival, a lot of us would transplant. So I think it was very interesting. Two cases of light chain deposition disease. 46 years old woman in 2018 diagnosed as FSGS, and she was treated in Mumbai with steroids, mycophenolate, rituximab, and the creatinine 2.21, urine protein 2+. There was some verbal history of mild abnormal free light chain and normal serum protein electrophoresis. IFE was not done. One relative in Ahmedabad noticed this and asked for IFE, and apparently that led to the diagnosis of this. And thereafter she had PET CT, bone marrow biopsy, all that. The bone marrow biopsy had only 3% plasma cells with lambda light chain monoclonality. And FISH was done, which was monosomy of chromosome 13 and hyperdiploidy, and cytogenetics were normal. Diagnosed as monoclonal gammopathy of renal significance. And then she was treated with bortezomib, cyclophosphamide, dexa, and her creatinine improved to 4 for several months. And in fact, she from July 20, creat was 6.3, and September 23. So she got about 3 years without going on to dialysis with this treatment. In May 2024, there was a repeat workup with a plan for thinking about transplant, kidney transplant now. So bone marrow biopsy was normal, and there was discussion about whether she should get the autologous hematopoietic transplant before going on to the kidney transplant, which has been kind of generally considered a standard that you have a good long remission from the light chain disease plasma disorder, and then you go to the kidney transplant. So because the cytogenetics FISH, everything had become now normal, the discussion was there whether this would be an overkill to do autologous transplant, and so she directly went to the kidney transplant in September 24, and now she is on maintenance bortezomib, and her CBC, free light chain ratio, serum protein electrophoresis, and IFE are remaining normal. It's early post-kidney transplant, so we'll see how it goes in the long run. And then there is another patient with a very opposite end of the spectrum, a very indolent disease, bilateral pedal edema in 2013, seen by us in 2015, create 1.2, albumin 1.6, very high 24-hour urine protein, very mild kappa lambda ratio abnormality, practically on the normal range you can say, and kidney biopsy was light chain deposition disease. Bone marrow biopsy showed a low-grade lymphoplasmacytic disorder. So CLL like. See that it's just not the plasma cell disorder, but even other lymphoproliferative disorder can also lead to light chain deposition disease. He was treated with only 4 cycles of cyclophosphamide and prednisone, a minimum aggressive treatment according to our standards, and he achieved remission and then received maintenance Landex, lenalidomide dexamethasone, from April 16 to 17, and then 5 years remained off treatment. So nothing required, he did well. Then he had recurrent edema and proteinuria, and pomalidomide dexamethasone was started, and after 11 months he is on maintenance pomalidomide. Because of cost issues in him, we are monitoring only the urine routine and CBC, and he has had a good time since then. Create everything has been normal, very minimum follow-up. So with that background of 2 very different aggressiveness of cases, MIDD, the monoclonal immunoglobulin deposition disease, are very rare plasma cell dysplasias. I will not go into all the details, but essentially light chain deposition disease, heavy chain and mixed light and heavy chain. And the light chain are 80% of cases, and among these, kappa is the 80% case. Now, the publications have included generally myeloma patients with deposition of light chain on the kidney biopsy. So there are very few publications where there is only light chain deposition. This is without a complete multiple myeloma. So multiple myeloma requires certain criteria to be met to have a diagnosis, not just the free light chain or even protein electrophoresis or plasma. So without having that, so there is a mix in these papers, but as you know that there are at least 3 main patterns: cast nephropathy from light chain, which is what we mostly assume, and we don't do kidney biopsy when we have a patient with multiple myeloma. And then there are light chain deposition disease, and then amyloidosis. So these are rare disorders occurring generally in the 5th to 6th decade, and it can occur with plasma cell dysplasia like multiple myeloma or Waldenstrom, or rarely with a B-cell neoplasm. And when most of these publications happened, we were not talking about this MGRS term. So it was either a full plasma cell disorder or it was nothing for us. Now only it is kind of converged that we have started thinking these as problems for us also. So the clinical presentations are frequently proteinuria, hypertension, and then if there is a glomerular involvement in more of a high the proteinuria and tubules and high creatinine. In one very recent large series of about 255 patients, the first time we have kind of realized that there is involvement of other organs like heart in 21%, liver in 19%, and peripheral nerves in 18%. Earlier we always thought that LPVD is simply limited to kidney and no other organ is a major threat. So the diagnosis requires the demonstration of the immunoglobulin deposits on the affected organ, generally kidney. In contrast to amyloid deposits, these are granular and do not bind Congo red. There is a linear staining and on electrons and the punctate powdery deposits. I'm sure you are more aware of this than I am. So these are, I think, this showing the same things on different stains. The laboratory features of LCDD compared to myeloma, then again confusion, myeloma with LCDD versus only LCDD. So now we're talking about this only LCDD, where serum total protein is normal to low, Benz-Jones protein is 100%. In some of the studies, there is a hypogammaglobulinemia. So the reason this is important is because we miss plasma cell disorder when we look at these numbers. So this would not look like a typical plasma cell disorder. Free light chain. Since the serum free light chain have come up, a number of these diagnoses have become easier for us because the pickup rate of a very low level of free light chain is better. Urine free light chain is even more sensitive, but earlier it was not routinely done, at least in the commercial labs that we work with. But now it is also available more widely. So as you see here that the protein electrophoresis is normal, but the kappa lambda is significantly abnormal. So for us, free light chain assay is extremely common test now. The confusion about diagnosis of plasma cell disorder comes from, for us, is because the bone marrow has very few plasma cells. So typically this bone marrow would have been labeled as normal because less than 5% plasma cells, there is nothing more to think. Now because of the awareness, we would do IHC on this and find monoclonality in these 5% or 3% plasma cells in that earlier patient that we saw. And we would now even consider doing FISH or other tests where we may find some other abnormalities. So now coming to the treatment. So the treatment is essentially targeting the underlying plasma cell clone and clearing that as rapidly and as deeply as possible so that there is the damage from the light chain is halted, and over the time the rest of the kidney which has been already injured can improve. So the earlier studies, so we go over those, but the chemotherapy and in selected cases autologous transplants were done in the papers that you see. One of the because it affects only kidney, the way we plan treatment, we think about this is that if kidney is whether the kidney damage is reversible or not. So one of the recommendations, these mainly are from the Mayo Clinic group, Shah and others. And what they say is that if kidney is irreversibly damaged, scarred, then they would not treat it. They would just monitor. So in light of this involvement of other organs now, heart and all, I'm not sure whether how long that recommendation would be and how to look for those more actively. But as of now, that is the recommendation. Now the publications are mostly very old, some are new data and the studies have frequently included myeloma. As you see one here, multiple myeloma is 58%. So very hard to compare the results of pure LCDD versus those including myeloma. And as you will see, mostly very old myeloma therapies have been used. Very recent ones have the anti-CD38 monoclonal antibody as well, and no all these studies mention only the first line of therapy. Whereas now in myeloma we have at least 16 medicines approved and we keep treating them multiple lines. So we don't even know whether after failure of one line in CDD, what happens with the second line or better treatment. That is very, very little data. And all the follow-ups were mostly 1 to 2 years, occasional are 4 years. So, so like we said, I think that the recovery of kidney function is unlikely in patients with dialysis-dependent kidney failure lasting more than a few months, and if the imaging indicates that the kidneys are small, scarred, and that should be left without any treatment. These patients should not be treated with the trying to clear the plasma cell clone. So other patients may recover kidney function, as we saw in our first patient where the creatinine had gone to about 5 and recovered, and about 3 years he had without dialysis. So for such patients the treatment is directed to similar to multiple myeloma or the B cell clonal disorder, whatever there is, and we continue that. How long to continue is not clear, because unlike the LCDD, where, as I said, there is no long-term papers you find, whereas in myeloma the treatment is very, very long. Either there is maintenance, multiple lines of therapy. As you can see here that the paper 2012 talks about only alkylating agents like cyclophosphamide, thalidomide, some lenalidomide, bortezomib, and then transplant. And all the studies have very few cases. And with single case reports, 1 or 2 patients, and short follow-up. So again, older studies saying the prognosis is generally poor and showing treatment as only corticosteroid alkylating agents, old chemotherapies, and some plasmapheresis, thalidomide, very no modern treatment. This one is a comparatively more recent paper from MD Anderson Cancer Center, where these are all biopsy-proven renal disease, and here again the numbers are fewer, 3, 4. One study has 25, otherwise mostly 3, 4 patients, and wide variety of treatments, DEXA followed by transplant, bortezomib, DEXA, bortezomib, DEXA, some old rad chemotherapy, thalidomide, bortezomib, DEXA. None of these would be considered a standard combination chemotherapy that we would use for multiple myeloma in the first line. And then a number of patients had transplant, and the survival is fairly good. You can say that about, of course, numbers are small, but a number of patients are alive at 4 years, 5 years or so. This is a comparison from the same paper showing that the hematological response based on the treatment regimen. So if it is transplant, then larger number had complete remission. This is complete remission, and these are partial VGPR or PR. VGPR for us means more than 90% reduction in the free light chain. So, and if it was bortezomib followed by transplant, again this is higher. Bortezomib based regimen, this is higher. So in general, bortezomib based regimen or transplant had better hematological complete remission, and the renal response also correlates with the same. So transplant, bortezomib followed by transplant or bortezomib, the renal response has a good correlation with the hematological response. Now, only one paper on the anti-CD38 monoclonal antibody daratumumab for relapsed patients, where the out of 8 patients, 7 had a good reduction in the free light chain assay, and out of which 2 patients achieved a kidney response, 4 had stabilization or improvement, and 2 continued to progress to end-stage kidney disease. So now in myeloma again, we would not treat with single agent daratumumab. So all these are much less aggressive treatment than what we would do in a typical myeloma. So coming to prognosis, if you see the 2003 publication is showing median survival 4 years and median time to end stage kidney disease 2.7 years. Whereas the more recent paper 2015 from National Amyloidosis Center in UK is the 5.4 years is the end stage kidney disease survival, reaching up to that. So almost doubling of the time to end stage renal disease. So at least there is newer data showing better results. Another paper showing 255 patients where you can see that 65 months median overall survival in those who had less than 30 GFR at the time of diagnosis. So even in those who had very low GFR, with the newer data, the survival is significantly better. And for those who had higher GFR, it's unreached. So the myeloma treatments have certainly improved the survival. Rapid diagnosis and achievement of deep FLC response were key predictors of prognosis in this data set. Now, to get to this, we have to use typically, if we do the myeloma type treatment, which is generally at least 3 agents like bortezomib, lenalidomide, dexa, and nowadays even daratumumab would be added to it. Then we can get a much better, much faster as well as deeper response. Transplant also leads to a deeper response. We don't do transplant as a first line, although in many of these studies transplant was the only treatment, like say after dexa of few months, transplant was done because that time options were low, and transplant can lead to deeper as well as more durable response. So that was supposed to provide allow the kidney to recover or not have ongoing injury from the light chain deposition. Now, what about transplant in these patients? So kidney transplant after the disease control. So the old data again showing very bad outcomes, that renal allograft survival is reduced significantly in LCDD patients, where they did I think 7 transplanted patients, and LCDD recurred after a median of 33 months in 5 of the 7 patients. 1 patient remains on dialysis, other 4 have died. And 1 patient died of progression of multiple myeloma 3 months after kidney transplantation without evidence of resection. And only 1 patient is free after 13 years with normal renal allograft function. But this is a publication of 2004. I think very likely that as of today the data would be better. So I think with the modern therapies where faster and deeper and more durable response is possible, it should be more patients should be considered for kidney transplant. Earlier also there is no concept of maintenance. Now maintenance in multiple myeloma is one of the only 3-4 treatments which actually improves overall survival. So maintenance is a very, very important thing. We give lenalidomide maintenance to patients even after transplant for 2 years, 3 years, 5 years like that. So when you are not giving maintenance, I think the recurrence of LCDD is going to be significantly higher. That also needs to be considered now when you are thinking of the risk benefit of transplant and what will be the outcome of kidney transplant. So in summary, For me, I would say that use the best available myeloma treatment if the kidney is still salvageable. If already end stage kidney disease, then treatment intensity needs to be decided case by case basis. Like the second patient, either very low intensity therapy or even observation potentially, but with more close monitoring of other organs at risk. So it should not be that we monitor only kidney. The standard first-line treatment for most patients will include bortezomib, lenalidomide, or in many of these studies they use cyclophosphamide as in amyloidosis with dexamethasone, preferably with addition of daratumumab, followed by autologous transplant. So for patients with low GFR, I don't use lenalidomide. I generally switch to pomalidomide, which is more effective, and since we have generic in India, we are able to do this easily. The studies in abroad, they don't use pomalidomide upfront that much because of the cost issue. So most important, I think, policy decision would be how aggressive to be in these patients with regard to the three drug combination as well as addition of daratumumab, because when we are treating myeloma, we are talking about patient survival. So I think it is easier for everyone to agree that we go full aggressive. With only kidney affected, I think the nephrologists are more worried about the treatment side effects, and this is a very common debate that we have with hematologists, neurologists, all other branches when monoclonal gammopathy of clinical significance is there. And so, I think I would say that the risk of these treatments are now much lower. That bortezomib, lenalidomide, dexa, or bortezomib, cyclophosphamide, dexa, and it would be worthwhile to start with the full anti-myeloma treatment, and possibly more likely to provide better renal survival. Uh, Now, autologous transplant, I can understand that it may seem too much to a lot of people, because yes, there is a 2% mortality, 2 to 5% depending on the age and comorbidities. And now, because we have many good medicines, even in myeloma, we have been postponing transplant. So compared to earlier, a lot of our guidelines and international speakers and every data says that you can postpone it to a first relapse. You don't have to do transplant at first time. So same way here, we could postpone it in the second line, and bortezomib, dexa or cyclodexa is a very cheap treatment now with so many generics. That is not a big issue. The transplant advantage is that if you have a patient who you think will not follow up, then that is you have given your best treatment, and even if it doesn't come after first 3-6 months, then you are okay, because you have achieved a very good, hopefully durable response, cleared the plasma cell flow. That may be the advantage, and now it is very cost effective. Certain trust hospitals would do it for 2-3 lakhs or zero even, and the Ayushman and other schemes have transplant also covered. So I think we have to start thinking more about the role of transplant. So maintenance, I have alluded to it earlier that in myeloma it is a must, whereas LCDD we don't see any studies showing the maintenance. Maybe we should think more of maintenance to have a better outcome. And monitoring is a big question, because about 10 to 20% have even normal, near normal free light chain like we saw in the last patient. And there, I think, so even the first patient that we discussed who was transplanted, he called me for second opinion that why do I need bortezomib maintenance now that all my reports are normal? Because her free light chain is normal, her bone marrow is normal, then she wants to end the treatment. She's tired of treatment going on for so many years. And we had this discussion that because if you have a very low free light chain burden which may be not measurable easily, but that could still continue to damage the kidney over long term. And we would not, because her initial numbers were also very small. So in such patients, I am not sure how to monitor and where to stop treatment. Those would be difficult questions to answer. And MRD monitoring, what we do for multiple myeloma now, where 0.01% clonal plasma cell can be picked up, is an option. But I'm not sure, again, because no studies for LCDD. But that is available. We use it for myeloma patients. It requires bone marrow biopsy. It's about 10,000, 15,000 rupees. So I think as we discussed that the myeloma prognosis has improved. When I started practice about 20 years ago, it was 1 year median survival, and now it is at least 5 years, and many patients cross 10 years. In fact, now our international speakers mentioned that if our patients don't cross 10 years, then they kind of do a quality check as to why this patient did not survive more than 10 years. That's the minimum expectation. So that is where we are. So I think we have to look at LCDD also from that angle, that such good medicines are available, and the patients who cross 15 years are considered operational cure. We haven't started using cure word in myeloma yet, so people say operational cure. So we have patients even in our practice, but from 15 years no treatment, after the transplant, initial 2 months of treatment, autologous transplant, and since then no treatment. So I think so again important to recognize the need to treat LCDD patients as actively and as early as possible before end stage kidney disease, since they don't carry the label of cancer as in myeloma. I think they are not treated as aggressively or as actively, let's put it rather. An aggressive word I think scares people. So as actively. Thank you.
Excellent session, sir.
So I just want to know how frequently we need to monitor the SLC in these patients, and because the renal failure also increases how to interpret in a renal failure.
So once you have cleared the plasma cell clone, even in patients with renal failure, the free light chain ratio should be normal. That should not be an issue. We monitor depending on the initial diagnosis. We would monitor even every 2 weeks. So the good part about the free light chain is you can get a very quick assessment of your treatment response. So 1 week or 2 week also you will know. Like we do plasmapheresis for patients with very high free light chain load and with kidney failure. Those are the patients where we still do plasmapheresis, and as the Mayo Clinic group also recommends. So after that it is every 1 month, then once patients are in better remission, then every 2-3 months.
We have time for one more question, then we will go for tea test.
So our bone marrow transplant that we are talking about is autologous. So luckily, autologous hematopoietic transplant will not require any immunosuppression. So you are, I think, talking about allogenic where, yeah. So here no, so that is why, autologous transplant has been used so much in multiple myeloma in frontline as well as in LCDD. because there is, after the initial few months, there is practically zero risk. There is no immunosuppression required.
Thank you. Thank you very much.